Welcome back, everybody. This is Jason Williams, and you're listening to our hospital medicine point-of-care ultrasound volume status curriculum. This is part 5, the very end of the train. If you have missed part 1, 2, 3, or 4, you can always go back to my website at proceduralist.org. We can review all those previous curriculums of volume status, which have covered a lot. In part 1, we talked about inferior vena cava measurement. In part 2, we applied that to central venous pressure assessment and volume status in congestive heart failure patients. In part 3, we learned about jugular vein ultrasound. And then we applied both IVC and jugular vein to a variety of chief complaints. But here in our final part 5, we're going over shock. And this is one of the more controversial areas. And if you've ever heard an emergency medicine physician or a critical care physician say IVC or ultrasound is garbage, it's because they manage shock a lot more than I do. I'm a hospitalist, and generally, if a patients are in shock, I am placing them in the intensive care unit, but I'll often do an initial triage and assessment, and I'll have those patients for an hour or two to try to either figure out, can I safely stabilize them in that period of time, or do they need closer care and monitoring in the intensive care unit? So I'm going to give you shock from the hospitalist perspective and how I think IVC ultrasound does have some utility, more so than what the critical care or emergency medicine physicians see. So let's talk about central venous pressure and shock in terms of diagnosis and initial triage. And then we'll also cover how to manage shock in terms of volume responsiveness versus fluid tolerance. And those are concepts where critical care and emergency medicine physicians get frustrated with IVC ultrasound, and we'll talk about some of the limitations there. So let's start with a case. This was a 27-year-old female with shock. She had come in with common bile duct stones and a lot of biliary colic-like pain. She'd been trying to get a semi-urgent ERCP, but it kept getting canceled and bumped for more emergent cases. So she'd been NPO for 3 days at this point. Finally got her ERCP to remove those stones today. Her past medical history is significant for lupus and severe pulmonary hypertension. She's chronically on 3 pulmonary vasodilators. And about 2 hours after her procedure, on the floor, she was noted to have tachycardia, a low blood pressure, lower than her baseline, 83/54, and she was on her baseline 2 liters HOMO2 for severe pulmonary hypertension. And she was feeling this low blood pressure. She was saying she was dizzy and orthostatic, and she was complaining of some stomach pain, but it was chronic compared to the last 3 days or so, not necessarily worse than before. And she was moderately tender and kind of epigastrum on palpation. So what could be causing her hypotension here after this ERCP procedure? So the first thing I started with is let's just look at her inferior vena cava and get a sense of what her central venous pressure is. And here, each one of these is a centimeter marker. So her IVC is much less than 2 centimeters and almost 100% collapsible. So she ends up with this very small IVC, very collapsible. She has a very low central venous pressure. So anyone in shock, I generally start with inferior vena cava or JVP ultrasound to figure out, do they have low to normal CVP? And if so, let's just give them fluids off the bat, because very likely this is a hypovolemic patient. And maybe we can look for bleeding in the chest or abdomen with ultrasound, or this is a patient with distributive or vasodilatory shock like sepsis. And either way, with a normal to low CVP, let's give that patient fluids right away while we figure out which one of these etiologies it may be. Versus the patient that if you look at their inferior vena cava or jugular venous pressure ultrasound and they have a high central venous pressure, then you immediately start to think about cardiogenic shock or obstructive shock etiologies. So this patient with her pulmonary vasodilators, most patients in her severe pulmonary hypertension, most of the time, physicians would be very reluctant to give that patient IV fluids because you're worried about worsening their right heart failure. But it turns out this patient, she had just been NPO for 3 days, got very volume down. We gave her fluids and she did just fine. And I felt much more confident giving this patient with severe pulmonary hypertension IV fluids because I saw this low central venous pressure. Turns out she had no sign of bleeding, pancreatitis, or any other complications, perforations, or anything like that from her ERCP. She literally just had to do with her being NPO for so long. And anesthesia in the ERCP was nervous about giving her fluids during the procedure because she had such severe pulmonary hypertension. But she did just fine once we volume repleted her. So in my argument, I think point-of-care ultrasound is essential for diagnosing shock. If we think about our common etiologies, Starting with IVC or JVP POCUS allows us to very quickly differentiate states that have low central venous pressure, in which case I can immediately bolus fluids. I'll often do a cardiac ultrasound as well, and we'll talk about kind of why that is. In our hospital medicine cardiac ultrasound series, we'll cover shock again, and we'll bring cardiac into the picture because it really is essential in your shock assessment is looking at the heart. But patients with low CVP, they're often in the hypovolemic or vasodilatory categories. And if you look at the causes of shock, sepsis is number one. Almost 2/3 of the time you get distributive or vasodilatory shock due to sepsis. Very rarely other causes of distributive shock. And hypovolemic's right up there around number 2 at 16%. So most of the time, about 88% of the time, giving IV fluids is going to help patients in shock. Again, I always recommend cardiac ultrasound regardless of the etiology of shock. But with patients with a high CVP, then our differential becomes different. You think about cardiogenic shock, which can cause shock 16% of the time, in which IV fluids would be detrimental to that case. And then you can use your cardiac ultrasound to look for reduced ejection fraction. And you can look at the lungs. So if it's left-sided heart failure, you'll have a bunch of B lines. So point-of-care ultrasound can help push you if you have a high CVP, reduced EF, and B lines. That's all very consistent with cardiogenic shock. Or the most feared category, obstructive shock. It only happens 2% of the time, but that's 1 out of 50 patients. And we're going to care for more than 50 patients in your career with shock. Some of them are going to have obstructive, which includes a massive PE, which you could see RV strain on point-of-care ultrasound. And then if you find a DVT in someone with significant RV strain and a high CVP, that almost makes a slam dunk for massive pulmonary embolism, which requires very specific therapy for. Pericardial effusions you can readily recognize as a cause of obstructive shock and tamponade. And finally, if the heart looks okay, you can always look for tension pneumothorax with lung ultrasound. So you can see, even though I start with IVC and JVP, point-of-care ultrasound can add a lot to further diagnosis of shock, including cardiac ultrasound and lung ultrasound, even DVT ultrasound from time to time. Okay, let's go with another case here. So this was a 74-year-old who had a history of heart failure with preserved ejection fraction. It originally came in with atrial flutter and acute CHF. The patient was originally admitted to the ICU for rate control. It was rapidly titrated up on moderate to high dose of metoprolol, 50 milligrams every 6 hours, was also started on lisinopril earlier that morning, and had got aggressively diuresed with IV Lasix for the past 2 days in the unit. They tried to transfer the patient to us, and during our assessment, the patient was hypotensive and altered. He couldn't wake up. He was drowsy and sleepy, and he had this new worsening blood pressure. So I could have just said, look, he's not stable for the floor. You guys just hold on to him. But we decided we wanted to help out the intensive care unit, figure out what was going on, and help them stabilize the patient, thinking point-of-care ultrasound might add to his assessment. So we looked at his lungs. There's 0 B lines, and he was on room air. He had no signs of cardiogenic pulmonary edema. He did have newly reduced ejection fraction down to 30%. He thought to have a preserved EF previously, but now he has new heart failure. And he did have 1+ leg edema. And here's his inferior vena cava ultrasound we did at the bedside. You can see his maximum diameter is 3.1 centimeters, and his IVC is only collapsing 34%. So what's his central venous pressure? He ends up in the highest category here. He has a central venous pressure of 15 millimeters of mercury. And so he's got a very high central venous pressure, reduced EF. Is this cardiogenic shock? Interestingly, during our exam, we had to lay him flat for about 10 minutes or so to do the cardiac, IVC, and lung ultrasound. And during that time, his blood pressure normalized, and he started chatting with us. He was perfusing his brain much better. So laying him flat essentially gave him a bolus of fluid, kind of like a leg raise. In other words, he had volume responsive shock in a patient that had very confusing volume status picture. So thinking about him a little more closely, his peripheral, when I think about his volume status, his peripheral edema, he had mild pitting edema of the legs, just 1+. He had no pulmonary edema, so his lungs were very dry, but had a high central venous pressure. And his effective arterial volume was clearly low, and that's as exemplified by his hypotension. So we were initially leaning towards, is this cardiogenic shock? But it turns out when he bolused himself fluids, when we laid him flat and the fluids from his legs entered his central venous circulation and entered his heart, he actually improved his blood pressure and cardiac output. So what caused this patient's low effective arterial volume? What caused his shock? It's multifactorial. And unfortunately, that's very common that these patients have a complex physiology where everything comes together to create this picture. But when we think about blood pressure or effective arterial volume, it's made up of your systemic vascular resistance and your cardiac output. Well, you remember he was started on vasodilators that morning. So he did have a vasodilatory component or distributed component to his low blood pressure. And he had low cardiac output. You'll remember that his EF was now 30%, partially due to the rapid titration of his beta blocker. That often reduces your cardiac output and decreased inotropy through beta blockade, and reducing his heart rate. So both his stroke volume and heart rate were reduced by the beta blocker potentially, as exemplified by his low ejection fraction. But stroke volume is also proportional to preload, and he had very aggressive IV diuresis for 2 days, so that hypovolemia can cause low stroke volume due to low preload. And so you'll recall when we do an IVC ultrasound, we're measuring his central venous pressure, which is a direct measure of right atrial or right ventricular pressures, which is right ventricular preload. So the preload in the right ventricle was very high, and that's usually correlates with left ventricular preload, but not always. The two can be discordant sometimes. You'll recall this patient had no B lines in his lung, which suggests that his left ventricular pressures were not markedly overloaded enough to push into his lungs and cause cardiogenic pulmonary edema. So thinking through this case in terms of diagnosis of shock, he had a hypovolemic component causing low stroke volume, low left ventricular preload. He had a vasodilatory component due to the lisinopril and vasodilator started earlier, and he had a cardiogenic component causing reduced ejection fraction and reduced heart rate from his beta blocker. So he had a multifactorial picture. And with this high CVP, it kind of allowed us to forget about some of these other components. So IVC does not tell the whole story often in these patients with shock. And you can see here why some critical care physicians and emergency medicine physicians get frustrated with IVC, because it doesn't always neatly categorize people into one category or another. So what happened in this case? Well, I'm going to argue it's difficult to predict blood pressure response to IV fluids. That has nothing to do with inferior vena cava. It's just hard to predict in general. So if we think about our classic Frank-Starling curves, as you give preload or fluids, otherwise known as left ventricular end diastolic volume, as you give fluids, you want to see your stroke volume or cardiac output increase. So here's a normal patient that is in shock. If you give a liter of fluids, you'll have a big increase in their stroke volume and cardiac output. At some point, after 3 or 4 liters of fluids, if you give another liter at liter 4 or 5, you won't get much increase in your cardiac output or stroke volume. And it's even worse if you have decreased left ventricular function like this case. So in this case, this patient was on this point of the Frank-Starling curve. We gave a liter of fluids approximately from his legs being bolus to his central venous pressure, and we got a small increase in his cardiac output, which helped his blood pressure. The patients we want to identify are those that have bad ejection fraction, that giving a liter of fluids is not going to increase their cardiac output and could cause problems like pulmonary edema. So how do we figure out who is at which curve and where they're at? It's hard. So you have to take 2 different measurements of cardiac output before and after a fluid bolus. So essentially you have to measure cardiac output first. And there's ways to do that with point of care ultrasound. We can calculate what's called a velocity time interval in the apical 4-chamber view, measure the left ventricular outflow tract and the peristernal long axis, and we can calculate cardiac output. It takes a few minutes, and if you're not accurate in your measurements, you're going to be off. So I don't recommend this as a beginner level point of care ultrasound skill. It takes time to learn and be accurate. And the last thing you want to do if someone that's dying in shock is like, sir, can you roll over on your side and we can do some fancy measurements? It's cumbersome. You're going to obstruct patient care. So advanced practitioners, this is a fun thing to learn, but not probably for early learners in terms of point of care ultrasound. Other ways to measure cardiac output is if you have an arterial line, you can measure pulse pressure, which is proportional to cardiac output. As a hospitalist, I have nobody with an arterial line, so that's not useful to me. And there's other fancy bioreactive devices that can measure cardiac output. Again, those are more commonly in the intensive care unit and not available to me as a hospitalist on the floor. But let's say you measure cardiac output, then you give a fluid bolus, and then you assess their cardiac output afterwards. So a couple ways to give the fluid bolus include actually giving them half a liter to a liter of fluids and then remeasuring cardiac output. Or on a ventilator, as the ventilator pushes pushes air into the chest, then takes the air out, you get fluid that enters the thoracic cavity and can give mini bolus as you expire on the vent. Or the passive leg raise that our patient had. He essentially had a passive leg raise that gave him a bolus of fluid from his legs into his heart. And then you can remeasure cardiac output. And this is just a very cumbersome thing to do, which is why detecting volume responsiveness is challenging in the critical care setting. So inferior vena cava, it's not sensitive for volume responsiveness, but there's some specificity to it. So for instance, if you look at all these different measures we talked about, like pulse pressure on an anterior line on a ventilator or with a leg raise, and compare it to measuring central venous pressure, let's say if our patient had a central venous pressure that was normal, less than 10 millimeters of mercury, that has decent specificity, but the sensitivity is not great. In other words, almost 40% of patients with a high central venous pressure will still be volume responsive, which is a lot. But the sensitivity is not bad compared to some of the other classic measures like pulse pressure, leg raise, and ventilator changes. There's some interesting data that if you have a patient on a ventilator and their IVC dilates by 15%, that's pretty specific and pretty sensitive for volume responsiveness. But again, as a hospitalist, I don't have anybody on a ventilator. But here's the data point I really like. That if your inferior vena cava collapses spontaneously with breathing more than 40%, that's pretty specific for volume responsiveness. In other words, if you see a dynamic inferior vena cava with more than 40% collapse, give fluids because they're very likely to respond to fluids. But a high central venous pressure does not rule out volume responsiveness, as we saw in this case. Our patient's central venous pressure was over 10, but he responded very well to fluids. So high CVP does not rule out volume responsiveness. You can often give fluids to patients with high CVP, and they can improve their cardiac output and blood pressure. Okay, let's apply that idea to this case. So here's a patient, 78-year-old with bad heart failure with an ejection fraction of 20%, who was admitted for acute CHF. Was initially hypoxic and had a very high central venous pressure, and after 4 days of IV diuresis, the patient was doing great. Their cardiorenal AKI was improving, but on day 5, they developed sepsis. They got febrile, tachycardic, and their blood pressure just tanked. There was suprapubic tenderness, and it turns out the patient ended up having a UTI. When we went to assess this patient at bedside, their lung ultrasound showed just 4 B lines, which is very mild pulmonary edema. They were on room air at this point, breathing comfortably. They still had a good amount of leg edema, 2+, and I would probably want to diurese that off, especially since their central venous pressure is still high. Look at this maximum diameter of 3.4 centimeters and a collapsibility of 41%. That puts them in the highest category, or a CVP of 15 millimeters of mercury. If not for the sepsis, I probably would have continued diuresing this patient given a high CVP and 2+ leg edema. But now the patient's getting hypotensive. So what should we do? Well, again, look at this collapsibility of 41%. Even though the patient has a high CVP, it's more than 40% collapsible. And as we learned, that's very specific for volume responsiveness. So giving this patient fluids today is going to help improve their blood pressure. It's time to prioritize their effective arterial volume for a day or two and control this sepsis. So when I think about their different compartments of volume status, I always think about them separately and decide which compartment am I going to prioritize today. And previously, we're prioritizing their peripheral edema and their central venous pressure and diuresing those compartments to dry them out since they still had a good amount of fluid. But today we got to prioritize their effective arterial volume. Their blood pressure is low, they're septic. It's time to stop IV diuresis and give this patient fluids. And in this case, his blood pressure responded very well to fluids and antibiotics. And so I stick to the surviving sepsis guidelines, and I do try to give 30 mils per kg of fluids in the first 3 hours, which is about 2 to 3 liters of fluids. I'll often break it up and maybe do half a liter to 1 liter at a time and reassess the patient. But the surviving sepsis guidelines have said, look, there is no central venous pressure goal anymore. That's another reason critical care and emergency medicine have stopped looking at IVC is like, well, we don't have to titrate fluids to CVP goal because it doesn't tell us who's going to respond or not. If the CVP is high, a lot of those patients will still respond to fluids. They do recommend dynamic measures to guide who needs additional fluids after the 30 cc's per kg. So that's when it comes in that after your first 2 to 3 liters, then you start doing fancy things like leg raises, pulse pressure measurement, measuring cardiac output to see who would benefit for additional fluids. Who needs 4 liters, 5 liters, 6 liters? Most people need 2 to 3 liters for severe sepsis, but who needs more than that? That's when those dynamic measures come into play. And they do recommend a point-of-care ultrasound of the heart to make sure you're not missing mixed cardiogenic septic shock or other causes of shock as well. So here's one of my philosophies that after the initial 30 mils per kg of IV fluids, consider early pressors in patients, especially with mixed septic cardiogenic shock. There's some really nice point-of-care ultrasound literature in this realm. So this was a nice single center study of an ICU patient population. They did pre and post POCUS implementation. They looked at patients that were admitted for 12 months before ultrasound was used, and then looked at people admitted during a 12-month period where they ultrasound everybody that came into the ICU with shock. And everyone got a cardiac and IVC ultrasound. Sepsis was the most common, but moderate to severe CHF was seen 25% of the time, so a lot of these patients had mixed cardiogenic septic shock. Interestingly, 80% of the time, this was new diagnosis of CHF. So even in your patients with sepsis that clearly have vasodilatory shock, this is another reason I always look at the heart, because oftentimes your ejection fraction will drop in the setting of new severe sepsis, or you'll pick up other contributing factors. And interestingly, by the time these patients made it to the intensive care unit, the emergency department had already done a great job of volume resuscitating with 2 to 3 liters of IV fluids. And as a result, most of the patients had a non-dynamic IVC. It was no longer more than 40% collapsible. So in the ICU, they often stopped fluids when the IVC was no longer collapsible, especially if the EF was low, and they started pressors and or inotropes early. And what they did by recognizing non-dynamic IVCs and low EFs, they reduced AKI and reduced mortality by stopping fluids and starting pressors early. And you can see these curves separate very quickly within the first couple days of shock in the intensive care unit. So just to kind of summarize in the next couple slides about how I approach shock as a hospitalist, again, I'm mostly doing triage initially to see if I can quickly diagnose the etiology of shock and see who I can stabilize quickly on the floor or who may need more aggressive care in the intensive care unit. So I'll often think about, is my patient volume responsive? And if I'm not sure, are they volume tolerant? Will it be safe to give fluids just to see if they respond? So I'll often give 500 to a liter and look for things. Did their blood pressure improve, heart rate improve, urine output, and how did their inferior vena cava collapsibility change? And I'll monitor for complications. Are they getting increased respiratory rate or distress? Are they getting new hypoxia? Are their number of B lines growing? And how is their heart doing with this additional volume load? Is their EF reduced? So again, I often measure the IVC early in shock. If it's more than 40% collapsible, I feel very comfortable bolusing fluids and then reassessing after a liter to see what is their IVC collapsibility and how are the rest of these parameters I'm monitoring for. Once the IVC is less than 40% collapsible, they may still be volume responsive, but then I think about, are they volume tolerant? How are their lungs doing? If there's no B lines or pulmonary edema, let me try some more IV fluids and see how their blood pressure, heart rate, urine output does with that and reassess. If they're getting pulmonary edema, I generally start pressors early, especially if they have reduced ejection fraction, and I transfer them to the unit much more quickly because this patients will benefit from stopping fluids and starting pressors in terms of the AKI and mortality improvement associated with that early transition to pressors and inotropes. All right, just to bring it home. So how do we apply central venous pressure ultrasound in shock? So it can help early on in the diagnosis of shock. If you look at the IVC or JVP early and it's small and collapsible or more than 40% collapsible, give those patients fluids. There's likely a hypovolemic or vasodilatory component to their shock. High central venous pressure should push you to look for more cardiogenic or obstructive shock etiologies. Again, if the IVC is more than 40% collapsible, they're going to respond to fluids very nicely, and I'm willing to monitor them on the floor for an hour or two to see if I can correct this hypovolemic or vasodilatory state. If their IVC is less than 40% collapsible, it's hard to know if they'll respond to fluids at that point. And then I ask myself, are they fluid tolerant? And I really recommend early transfer to the ICU if their EF is down and they're developing pulmonary edema. Those patients really seem to benefit from less fluids and early initiation of vasopressors. All right, and that is it. Congratulations. At this point, you've completed all parts of the hospitalist point-of-care ultrasound volume status curriculum. Again, if you want to rewatch any of these videos, you can return to my website at proceduralist.org at any time. And at this point, I recommend practicing image review, doing quiz questions, and image integration. And you can find that at my website as well as proceduralist.org to review a lot of these concepts with quizzes and interactive material there. Thank you again for joining,